안녕하세요.
Hello, I'm Dr. Son Young-hui. After we do the implant surgery, the initial healing period is very important to prevent infection and inflammation during the period and to reduce patient's pain. We prescribe drugs. It is important to understand the efficacy and side effects of drugs. Let's look at prescribable drugs and what are the appropriate prescriptions that we can make clinically. Today, I'm going to talk about first how we can prescribe drugs safely. And we prescribe a lot the antibiotics and anti-inflammatory drugs. Lastly, we will look at the side effects and the drug adverse effects after dosing, how to manage them. When we examine patients in our office, conservative procedure and invasive operation need to be done at the same time. Various drugs are prescribed for the procedures, depending on the purposes of the prescription. And we can classify like following: pre-op patient management and the post-op patient management. Apart from that, we also prescribe drugs to manage patient pain and discomfort. The risk of medications classified by FDA in terms of the impact to fetus and pregnant women. A is the most safe one, and most drugs we prescribe would fall into B, C, or D. And if the drug is B, but if it is used for a long time, then it can fall into class D. The common antibiotics, there are about 15 groups used a lot. Let's have a look at each of them. The most frequently used antibiotics is the amoxicillin. It is better in terms of the absorption than ampicillin. The standard prophylactic antibiotics is amoxicillin. The dose is 250 to 500 milligrams, 3 times a day. The disadvantage is that it is not effective for beta-lactamase producing bacteria. Many drug-resistant bacteria, the side effects are diarrhea and nausea, and it reduces the efficacy of oral contraceptive, anticoagulant, or antihypertensive drugs, but most antibiotics reduce efficacy of those drugs. To have a resistance to beta-lactamase producing bacteria, augmentin is available. Augmentin is the antibiotics combining amoxicillin and clavulanate. There are 3 doses: 187.5, 375, and 625 milligrams. For adults and 12 years old or older, 40 kilogram or higher adult dose is used. That is amoxicillin 250 milligrams per dose. So amoxicillin 250 plus clavulanate 225, therefore 375 milligrams 3 times a day, every 8 hours. The augmentin will be less effective when exposed to air, so it should not be exposed to air. In dentistry, for infection, amoxicillin is used 250 per dose 3 times a day for 5 days. The similar effect is achieved with the Unecin. It is a combination of ampicillin and sulbactam. Instead of amoxicillin, ampicillin. Instead of clavulanate, sulbactam is used. The next most used one is cephalosporin. There are generations, usually generation 1, 2, and 3. What we use are generation 1 and 2. Cephalosporin is the representative drug in the first generation. It is stable to penicillinase and beta-lactamase and also has a similar effect as augmentin. Depending on severity, 250 mg to 500 mg can be administered 2 to 4 times a day. The main second generation cephalosporin drug is Cefaclor. As you go up the cephalosporin generation, it is effective from gram-positive to gram-negative. Resistance to beta-lactamase increases as you go up the generation. However, in early oral infection, gram-positive is dominant. At early stage of inflammation or infection, it is not good to use cephalosporin right away. At the beginning, you need to use amoxicillin. After abscess is formed, cephalosporin needs to be used to be more effective. As for the Cefaclor, for adults, 250 mg is administered 3 times a day or 375 mg twice a day. As you can see, the absorption rate in the body is not affected by food intake, so it's easy to use and it can be used for patients with renal failure. As for children and elderly, it is very safe. So it is sold a lot in the syrup form. For children, you can memorize like this. You can calculate like per day 20 mg per kilogram and administer it like 3 times a day. The maximum daily dose is 1 gram. On antibiotics used a lot by dentists, metronidazole and spiramycin are combined in Rhodozil, which is used only by dentists, not by medical doctors. Rhodozil is a combination of metronidazole 125 mg and spiramycin 750 KIU. This antibiotics has antimicrobial effect for all aerobic gram-positive, anaerobic gram-positive, and gram-negative. So it has antimicrobial effect in many areas, but that is not always good. The side effect of the drug is it increases the blood concentration of anticoagulants. So you need to reduce the anticoagulant dose or stop the antibiotics and switch to another drug. Next, quinolone family. For patients allergic to penicillin, it is a drug of choice. The half-life is long and you can prescribe once or twice a day. Next, roxithromycin. It is in macrolide family, so this can be an alternative prescription for patients with penicillin allergy. Especially, the roxithromycin does not have a contraindication of age or pregnancy. It can be safely prescribed for 150 mg dosage. It can be prescribed even as twice a day. Lastly, tetracycline. It has not been used to manage the infection for a long time, but after periodontic treatment, especially after curettage, it is prescribed. Dentistar or Dentaclean are mainly prescribed. The drugs don't have treatment dosage. For doxycycline, the standard dosage is 200 mg per day. The low-dose tetracycline, Dentistar or Dentaclean are prescribed 40 mg per day. Each pill has 20 mg. So during or after period treatment, they can be prescribed for 4 weeks under the National Health Insurance. However, the FDA safety category is D. You need to be careful for pregnant women or childbearing age patient. This is the antibiotics regimen for a dental procedure for prophylactic purpose. This guideline is from the American Heart Association. This is to administer antibiotics before a dental procedure. Of course, this is a guideline to prevent infective endocarditis. However, clinically, it is desirable to follow this guideline. According to this guideline, 30 to 60 minutes before surgery, amoxicillin 2 grams administration is recommended just one time. For a patient allergic to amoxicillin, other drugs like cephalexin, clindamycin, erythromycin, or clarithromycin can be prescribed. Second, for therapeutic purpose, when infection occurs, this antibiotics selection guideline can be used. Various papers are summarized here. In most papers, in most oral infection, Streptococcus is dominant. And this is the antibiotic sensitivity to Streptococcus. The high sensitivity is in the first group, vancomycin, teicoplatin, chloramphenicol, ofloxacin, amifenem, and erythromycin. However, most of the antibiotics are not appropriate to use clinically. So clinically usable ones are ofloxacin and erythromycin in the quinolone family, and antibiotics with the intermediate sensitivity are ampicillin and sulbactam, clindamycin, ciprofloxacin, cefotaxime are the third generation cephalosporin. These antibiotics have intermediate sensitivity. Up to here, we can use them, but the high resistance ones, like cefazolin, oxacillin, and ampicillin, show high resistance. Therefore, for oral infection, antibiotics with high resistance should be avoided. We need to use a high sensitivity or intermediate sensitivity antibiotics. And secondly, most infection shows in the form of abscess or cellulites. Before abscess is formed in the cellulite stage, aerobes are dominant. Therefore, penicillin family is much more effective. Once abscess is formed, aerobes are replaced by anaerobic bacteria. Thus, to prescribe antibiotics for abscess at early age, amoxicillin is desirable to be prescribed. After pus is formed, the drug needs to be changed to the second or higher generation cephalosporin like macrolides or quinolone to control the patient's infection. NSAIDs stands for non-steroidal anti-inflammatory drugs. It is defined as all anti-inflammatory analgesics except the opioid analgesics and steroids. If you look at the drugs briefly, ibuprofen is used most widely. FDA classification of B, D are indicated. Originally it's B, safe drug, but it is a D category when it is used for a long time. Brufen and Advil fall into this category of ibuprofen. This is very safe, so up to 3,200 milligrams per day can be used, and the analgesic effect is superb. However, there's one disadvantage. The half-life is very short. Thus, for proper analgesic effect, it should be administered every 4 to 6 hours. It is in the form of a syrup. That means it is safe for children as well. Second, diclofenac sodium. Diclofenac is explained because it is the most popular NSAID. In Korea, it makes up 1/3 of a prescribed NSAID. One of the side effects of NSAID is to increase the risk of cardiovascular disease. Therefore, long-term use is not recommended. Aceclofenac is stronger for COX-2 selectiveness and reduces the GI side effect. So this is widely used too. In the picture, Eltal is not diclofenac but aceclofenac. Next is loxoprofen, which is widely used. It is for rheumatoid arthritis and osteoarthritis, and is also used as anti-inflammatory analgesics after surgery or extraction after trauma. This should not be used with the ketorolac, which is another NSAID. Next, piroxicam. It has various dosage forms. Frequently, we see in the form of patches. It is a strong NSAID with a strong anti-inflammatory effect. However, it may cause GI side effect or skin side effect. They can be a little severe. In the past, the standard dosage was 40 milligrams per day, and now it is lowered to 20. Next, ketorolac, tromethamine. Tarasin is a drug name, brand name. Ketorolac, compared to other NSAID, has superior analgesic effect. So it is used to control pain, and it is the most powerful analgesic drug except opioid analgesic. However, many drugs should not be used together, and it is not for 16 years old or below, and it should not be used more than 7 days. Ketorolac drug, the similar drug, should be avoided as much as possible. That's why I'm showing this to you. Next, now we are using a lot of this, and also orthopedic department uses Ultraset. Let me talk about tramadol and Ultraset together. Tramadol is not an NSAID. It is a pseudo-opioid. It is closer to opioid. The drug does not have a fever-reducing or pain-controlling effect. It has only analgesic effect. The mechanism is similar to opioid, but it is not an opioid. Therefore, we can prescribe it. The NSAID that we use work on the peripheral nerve, but tramadol works on CNS, and there's withdrawal symptoms. Ultraset is discussed together with the tramadol because Ultraset is a combination of acetaminophen and the tramadol. It is made by Janssen Korea. There are many formulations and dosages. It is most widely used in orthopedic department. The analgesic effect is very strong, but it has strong side effects. Therefore, if it is not absolutely necessary, you need to be careful in prescribing this. Next, acetaminophen as a single agent. It is called Tylenol or paracetamol. It doesn't have anti-inflammatory effect. It is not an NSAID. Very safe product, but liver toxicity can develop if it is used excessively. 3 grams is the maximum allowance per day for adults. The patent is expired, therefore 23 to 2,500 generic drugs are available in Korea. WHO established principles for prescribing analgesics, and this can be applied to oral infection. Step 1 for mild pain, Step 2 moderate pain, Step 3 for severe pain. So 3 steps of pain. When the pain is mild, non-opioid NSAID only can be used. For moderate pain, weak opioid plus non-opioid or adjuvant can be prescribed. For Step 3, severe pain, strong opioid and non-opioid can be administered according to this recommendation. For analgesic letter, what is more important is not this, because we don't chronically use the painkillers. What is written at the bottom is really important. What does it say? Combining an opioid and non-opioid is effective. That's what it says. But we should not combine drugs of the same class because the analgesic effect does not increase. Second, depending on the drug half-life, the drug should be administered, the dose by the clock. That's important. And we should not wait for pain to recur. These principles need to be adhered to. When we say side effects, they usually refer to the adverse drug reaction, ADR in short. It is an hazardous or unintended reaction while using the medication in normal usage. So the adverse drug reaction is the side effects. There's another word, adverse event. It is all the signs, undesirable and unintended signs during administration or use of medication. So when we say side effects normally, that means the adverse drug reaction, ADR. In Korea, what causes ADRs? According to papers, NSAID. NSAID ADR is the most frequent one, followed by anti-cancer drug, and then antibiotics. First, adverse drug reaction of antibiotics. The most frequently, amoxicillin causes the ADR. The adverse drug reaction, most frequently, shock occurs, and hypersensitivity and GI trouble. Rarely, hematologic problem, CNS problem, skin problem, hepatic, and renal problems. In the past, for shock and hypersensitivity, H1 antihistamine or corticosteroids were prescribed first, but today the use of epinephrine is recommended first. When we administer epinephrine to a patient, we can use the emergency kit, 1 to 1,000 epinephrine. For adults, usually 0.3 milligram is administered. EpiPen or Zext are available locally. And they can keep that at home after getting the prescription from hospital. The expiry date is usually very short. After the expiry date, they should throw this out. Still, it's better for them to keep one at home. It is an auto-injection. A patient can inject it at the outer side of the patient's thigh, then the injection automatically occurs. The second ADR of antibiotics is GI trouble. Nausea, vomiting, diarrhea are the most frequent ones. Rarely, pseudomembranous colitis can occur. Pseudomembranous colitis, I have never seen it, but it is very fatal, high death rate. Macrolide has the high probability, the high incidence of this. Clarithromycin or oxythromycin can be prescribed, but the long-term usage is not advised. But there is some misunderstanding. GI trouble due to antibiotics is very rare. That's you need to understand. For GI trouble because of antibiotics, antacid or digestive do not help. After prescribing the drugs and a patient develops GI trouble, mostly that's because of NSAID. Next, drug adverse reaction of NSAID. ADR of NSAID. It is because of inhibition of COX-1, and it has so many ADRs like this: GI trouble, hepatic, renal, hematologic, respiratory, cutaneous, and CNS troubles. Among the NSAID side effects, the most frequent one is the GI trouble. In 40% of the cases, stomachache, heartburn, abdominal distension, indigestion can occur. 40% of all the troubles. Next, the GI, bleeding, perforation, or occlusion, very severe. Side effects can occur rarely. The risk factors of developing those are about 7 items. First, age, history of ulcer, high dose of NSAID, and concomitant use of multiple NSAIDs, antiplatelet agent or anticoagulant, corticosteroids if they are used concurrently. Those are the risk factors. If those risk factors exist, then there's a higher probability of having the GI ADR. The probability of having GI ADR depends on which drug is used. The biggest culprits are endomethacin and ketorolac, followed by naproxen, diclofenac, piroxicam, meloxicam. So ibuprofen is a very safe NSAID. When GI trouble occurs in a patient, can we suspend the use of NSAID? It depends on whether it can be suspended or not. If it is yes, proton pump inhibitor, H2 antihistamine, or misoprostol can be prescribed. If it cannot be suspended, PPI or misoprostol can be administered with the NSAID. Here, H2 antihistamine is not included because H2 antihistamine includes cimetidine or ranitidine. These drugs need high dosage, so for GI trouble case, NSAID should not be used with that drug. After NSAID administration, GI trouble can occur. To manage that, first we need to suspend the administration of the drug. If that cannot be done, patients are classified into 3 risk groups. For high risk group, NSAID should be stopped or COX-2 inhibitor should be used, and misoprostol or PPI can be concomitantly used. For moderate risk, NSAID is not stopped. It should be changed to COX-2 inhibitor or NSAID plus misoprostol or PPI. For low risk, no prevention. Misoprostol, PPI have been mentioned. In terms of the efficacy, PPI is the best, and then misoprostol and H2 antihistamine. Misoprostol is a prostaglandin analog, and when it is used repeatedly, GI trouble can occur. So rather than using misoprostol, PPI needs to be used. Omeprazole or esomeprazole are PPIs. H2 antihistamine is a gastric acid secretion inhibitor, but the standard dosage is not good enough. Therefore, 2-fold dosage needs to be used. PPI blocks gastric acid secretion and is the most effective one. However, if it is used for a long time, there's a risk of CDI. Other than these drugs, COX-2 selective inhibitor, which hardly blocks COX-1, can be prescribed for long-term use or GI trouble. It reduces the peptic ulcer 4 to 5 times, but cardiovascular failure can occur as a side effect, so it is advised not to use it in CV patient. All drugs have side effects in addition to the desirable main effects. Unexpected side effects can occur. So when we use drugs as described in this diagram, we need to use the lowest effective dose for the shortest period of time. So up to now, I have given you how to manage a patient after implant surgery, and when infection occurs, how to manage the infection. I hope this lecture has been helpful to you. Thank you.
때 조금이나마 도움이 되셨으면 감사하겠습니다. 이상입니다.